So my name is Vetisha McClair, and I am actually from the Center for Medicaid, Medicare and Medicaid Services, particularly in the Center for Medicare and Medicaid Intervention, CMMI. So our center does a lot of incubation for what CMS is considering our innovative projects throughout the country. We're housing some of the more nationally known projects in innovation within the sphere of public health insurance. So that would be ACOs. We also have Healthcare Innovation Challenge Awards, 107 awards for the first round, and now I believe 23 for the second round of just innovative projects throughout the United States. What this project is actually looking at some healthcare expenditures for children with disruptive behavior disorders in Medicaid and CHIP. There we go. So many of you may know Medicaid and CHIP basically is the largest source for health care for children in the United States. CHIP is the Children's Health Insurance Program, and Medicaid, of course, is a state-run health insurance plan for low-income families. The benefit packages, of course, differ from state to state, and it's a partnership between the federal government and individual states on kind of the reimbursement for healthcare services for very vulnerable and low-income populations. So Medicaid and CHIP is a primary source for health care for low-income children throughout the United States. And Medicaid is or CHIP is in most all states in the United States in some form or fashion. Children who are not eligible for care under their parents' insurance or their parents are lacking insurance are always eligible for care under CHIP. Few studies have actually looked at the expenditures for children in Medicaid and CHIP in general, and so this is some information that we've used particularly to focus on those with disruptive behavior disorders within this population. Disruptive behavior disorders, if you're not familiar with them, primarily are these three. They're conduct disorder, oppositional defiant disorder, and ADHD. Conduct disorder, of course, is characterized by kind of a disregard for societal norms and the rights of others. ODD, or oppositional defiant disorder, is characterized by kind of persistent patterns of anger and breaking rules. And ADHD is characterized by deficits in attention and potentially hyperactive behavior. So these conditions can become a large burden on both familial and healthcare resources, and they also significantly limit the educational experiences of children diagnosed. We found, or researchers actually found, that there's definitely a connection between disruptive behavior disorders, specifically conduct disorder, and the occurrence of later personality disorders such as antisocial personality disorder. And also what we found is that educational attainment for children who have ADHD and also conduct disorder and or oppositional defiant disorder is significantly less than those without. So many children diagnosed with DBDs experience impairment that persists into adulthood. So it was important to do this study, one, to look at this data source as a source of information that will help inform policy, but also to understand more about a population that we don't necessarily have as much data on. And given the richness and potential value of Medicaid data, it seemed a perfect source of information to look at a study like this. So I'll present information from actually two studies that we've been looking at. First, we've looked at kind of general prevalence and expenditures for the treatment of disruptive behavior disorders, and then we decided to do a second study where we focus specifically on the pharmacological treatment for those diagnosed with DBDs. So just a little bit about the data source. We use the Medicaid analytic extract. Essentially, these are person-level and claim-level files that are compiled annually. MAX data is basically claims-level data that was submitted for payment that we then utilize for general research and also policy purposes. The MAX files contain eligibility, service utilization, payment information, and they're derived from state reporting to CMS nationally for payment. Eligibility files were we combined those with healthcare claims from their inpatient, outpatient, long-term care, other, and prescription drug to develop a comprehensive data set of the healthcare that children receive throughout the United States. Interesting to note about Medicaid data is that the eligibility and services package is actually largely determined by the states, and they can differ widely from state to state. Some states cover some things that states do not, that other states do not, and some states cover various kind of conditions, and kind of the criteria for getting on Medicaid and CHIP can vary widely. Children are a little bit of a protected class because, like I said, CHIP would cover any child that is not eligible for insurance in other places. So while Medicaid claims are very useful in examining national trends and also within state healthcare policies, comparisons between individual states are probably not recommended just due to differences in benefit packages, data quality, and also individual issues that may occur within a state from year to year that actually may significantly impact the state of healthcare and also Medicaid within that state. So this is more of an overall look. This is kind of like our 5,000 kind of 5,000 mile kind of look ahead about kind of children's health care within the United States. Our overall prevalence and expenditure study, we were able to extract and examine the claims actually for 46 states plus the District of Columbia. We're still analyzing the data from our two of our largest states, which is California and New York. We're expecting to combine that information in the next few months. It's just analytically, these are millions of individuals, millions of claims, and billions of dollars being paid. And some states have inconsistent qualities of data, and so there are some states that we are going to naturally exclude because we aren't sure of the data quality. And so for our first study, we've excluded Maine and Alabama for that reason. And then the second study, which is a smaller subset of the first study, we were able to actually analyze the data for 49 states plus the District of Columbia, and only excluding Maine kind of for some data quality issues. So the sample, just in general, they're Medicaid or CHIP beneficiaries. We looked from 2006 to 2009. We have some data for 2010, but it is not complete. When states report that data to CMS varies, and also it takes a while for those claims to also be processed into MAX files and make them usable for research and also policy purposes. We looked at children and teens under 20 with at least one diagnosis or in a health service claim of conduct disorder, oppositional defiant disorder, and or ADHD. And we analyzed these outcomes by sex, age, race and ethnicity, state, delivery type, either fee-for-service or managed care. So essentially, the difference is, of course, some individuals can be paid per claim, so fee-for-service, essentially you have a service and then you provide a payment for it, or managed care organizations which contract with local states to provide their Medicaid insurance program. So I'm not going to present all the information here due to time and just due to the fact that we wanted to be focused on kind of some of the major highlights of this data and also the uses of the data in general. So we looked at a number of different outcomes. Of course, we wanted to do total prevalence, so number of beneficiaries with a DBD, and then also the prevalence rate among Medicaid beneficiaries. And then we also looked at expenditures, so total Medicaid payments for everyone under 20 years old, and then also payments for individuals with a DBD and DBD treatment. And then we also looked at the per beneficiary per year, or PBPY payment. So this chart, which of course has a lot of numbers and is quite colorful, I would just draw your attention to a couple of things that are really important to notice. So if you look in the yellow column, essentially the prevalence rate of DBDs among Medicaid beneficiaries has increased slightly. So 4.7% in 2006 to 5.3% in 2009. The number of beneficiaries, so coincidentally also, if you look at the second column, the number of beneficiaries with the DBD has also increased slightly for 2006 to 2009. overall number of beneficiaries has actually had a large increase. We've had from 2006 to 2009, which is in actually the first column, we have had almost a 3 million increase of 3 million children being eligible and on either Medicaid and CHIP in these 4 years. And so what we found is that while we've had definite increases in overall payments, so that would actually be in the blue column, the payments for DBD treatment are actually not as significant, hasn't increased very much and has remained relatively flat, and that would be in the green column. So just to look at this graphically, you can kind of see the same things that I'm talking about. So the trend for a Medicaid paid amount in figure 1, you can see the total payments have definitely increased. However, those payments for beneficiaries with a DBD and the total Medicaid payment for treatment, the red and green lines, are actually relatively flat. And also you can look at the proportion of paid amounts. So essentially what you find is that while the percent of treatment, of DBD treatment payment to all treatment for kids with DBDs has actually decreased. And you found that the DBD prevalence, while the DBD prevalence with Medicaid has remained relatively flat. We analyzed this information by racial group, and what we found was that essentially the prevalence has remained relatively stable in racial groups. But there's overall a higher prevalence of these disorders within white, which is the blue column, and also Hispanic or Latino children, which is in the green column. So it's important to note that the overall prevalence and expenditures in Medicaid and CHIP for individuals with DBD has increased, but the payments devoted to DBD have actually remained relatively stable. And the overall healthcare expenditures for this group has actually increased, which results in a slightly decrease in the proportion of expenditures devoted to mental health. White and Hispanic or Latino children were more than twice as likely as children of other racial groups to be diagnosed with a DBD. So quickly we'll go to our second study, which is the prescription drug prevalence. And what really is important here is understanding that these results are fairly consistent with the general prevalence rates. What we're finding here is, of course, smaller increases in expenditures for individuals with a DBD, but we're also finding very high rates of use of prescription drugs. So that would be the third column, any RX use. So we found a 25% increase in the use of prescription drugs for individuals that have disruptive behavior disorders. However, you see relatively flat actually increases for the per beneficiary per year information, which is of the Medicaid paid amount, and the prescription drugs filled column. So 2.6 and 1.3% increases only. And what we looked at here is the prescription drug fill numbers, which is essentially a child can go to a doctor and get a prescription, but it's not necessarily that they will fill that prescription. So it's important to look at kind of how many of those prescriptions were actually filled as opposed to just how many were written and things like that. And then we also wanted to look at the Medicaid paid amount. So the blue column is the Medicaid paid amount. What you find is that while across years that they have remained relatively stable, we've had some slight increases, very small increases from 2006 to 2009, and the prescription drug filled numbers have actually stayed quite stable within those years. So the total number of prescriptions and the Medicaid payments have increased very slightly, but what we found is that a large proportion of the drugs that are prescribed to children with DBDs are actually psychotherapeutic drugs, and that proportion has remained relatively stable through and within, relatively stable for all beneficiaries and within racial subgroups. And so I just want to end with some conclusions. Essentially, these results should be kind of taken into account with a number of exogenous factors, I mean, delivery system reform is happening within the states, and so we have to make sure that we understand what's happening within the state and state level changes and how that actually may affect the numbers that we're seeing. And also, further research really needs to understand not only the cost of the treatment, but also how state by state and how managed care actually plays and how the money that we are providing for this care is being allotted. Medicaid data is, of course, a very viable source of information about the state of health care for vulnerable populations, particularly low-income children, and also understanding kind of the medical expenditures for children with these conditions is really crucial for us to instigate kind of changes in the healthcare system. And so we really need to kind of continue research in this area and continue use of data, continue use of Medicaid data for both research and policy purposes. So I'd like to also thank my collaborators within CMMI. Thank you.